Record. All right. Thanks everyone for joining us and for switching to virtual. We really appreciate it. This is our fourth session of the Autism Learning Community. Today we'll be focusing on taking in autism history and discussing those findings with families. We have Dr. Carol Weitzman and Dr. Julie Bickle joining us again tonight. This is a look at our agenda. We are going to talk about the homeworks and structured observations, and then we'll get into the content. And at the end, we have some time for role plays. You can chat your name in if you're watching with someone else, just to make sure you all get credit. Course credits, just a reminder, if you are seeking MOC credit, I have some soft deadline guidelines for the coursework there. It's 2 quality improvement cycles, PDSAs, so let me know if you have questions. I think I've heard from everyone that's seeking credit, but if not, reach out and we can work on your projects together. Happy to do that. And now I'll turn it over to Carol to go through the homework.
And Carol, I just put everything on one slide here just to be sure. I wanted to sort of keep time appropriate and remind everybody that we sort of hadn't reviewed homework 4 last time.
So we did do 4 already, John? I'm trying to remember. Did we?
4 was the one that was a little bit of confusion about, if I remember that.
You know what? Let's do this really loose. What did everybody practice this week? Did you find, right? What did you find an opportunity to practice some of using a structured observation to kind of appreciate the range of responses that kids might have? What did people, what did you do since we've last seen each other? And by the way, so sorry that we're not all together in person tonight. I really love it when we have our in-person get-togethers. I think it's, I don't know, it's more convenient certainly for many of us to be on Zoom, but there's something really nice about being together. Anyway, tell me what you guys did.
So one of the things that Sarah Zombeck and myself did was we got a couple of nurses to volunteer their 2-year-olds to come to the office, and we practiced structured observations on them. So that was kind of fun to try and figure out and to just kind of get the flow of things.
So tell us about that. That's fantastic. That's great. Did you videotape yourselves?
We didn't, because it was the first time and I was nervous. I think Sarah.
I understand.
Sarah's done this before, but yeah, I mean, we had all the toys and we have a behavioral health part to our office. So we went into one of those rooms where there's a couch and a table that's down low. So it's not an exam room. And so it was very helpful to sort of see how a neurotypical kid would just come in and, having a little bit of a debrief with the mom ahead of time, saying, don't say much to the kid. And obviously using the cheat sheet that you gave us as well. I think it was really helpful to have another person in the room. So the first time Sarah played with the kid and did everything, and then I wrote down the observations, and then the second time we flipped. And that was really very helpful because you didn't feel like you had to remember what to propose next to the kid and what to show next to the kid, as well as write down what you had just observed. And it was a good way of dividing up the work, I guess.
It's like amazing if you can have 2 people present. I mean, it's a beautiful luxury because it is a lot to be in the moment with a kid and taking notes. And when it's, and I'll answer your question in a minute, Ruth. And it's just a lot. It's just a lot. I mean, honestly, even like to this day, I still find it a lot. Like there are times, I've said this to you guys, like there are times I kind of amaze myself at how bad my notes are afterwards. I'm like, wow. You think I'm writing a lot of stuff down, and I use a lot of shorthand so that it'll trigger a memory. And I've become very disciplined about like writing my notes right afterwards, because otherwise I honestly, if I see a lot of kids in a day, it blends together. And by the end, they all, so it's a beautiful luxury to have more than one. So Nuria, can I put you on the spot a little, really in a good way, I hope? Just tell us what you saw. Like, so when you saw, let's just assuming that these were neurotypical kids.
They were absolutely, they were
So
very verbal kids. And I mean, I don't have my notes in front of me of what exactly
that's all
was.
right, just wing it.
Yeah, so basically, definitely, you know, even just from the get-go, seeing how verbal they were, engaging with some of the toys, and then showing them to us as whoever was the initiator, um, and kind of being, look how cool this is. It makes noise, you know, because we have a couple of like, you know, a phone that makes noise, whatever. Um, and they were checking in with the examiner or the person conducting the observation, which we thought was interesting. But both of these kids actually go to daycare, and so we thought, well, maybe they're just used to, you know, communicating with a teacher. They didn't just automatically just go to the mom. It was interesting also to see that sometimes some things were a little bit harder to elicit. So reading the book after you've had all those beautiful and amazing toys in front of you is really not a fun thing to do. And so we're like, we have a clear bin with the toys in it. We're like, we should get an opaque bin so they can't just still see the toys and look for them. They were really good at cleaning up. I mean, they did a lot of really great stuff. And it was interesting to see some of the time when they would be like, well, it took me a little time to have them share this with me, kind of thing. It took me a couple of tries to do that. And that's a normal thing. You know, you're not always going to get it on the first try when you try to sort of do something.
But here's what I guess I want. That this is so great. So I would say that you want to kind of use the language of, so looking at, although they may not have been sharing with you, what were the other social or communicative behaviors you were seeing? Describe those,
Oh,
what
they
they
were
actually
very
were.
versatile. They would label a toy and they would say, "This is a phone. Look at this phone." You know, like they were just very interactive. There was great eye contact with us. There was a lot of good nonverbal communication as well. Um, and
Like nonverbal, like what? Pointing, shrugging, what?
yeah,
Tell
so I was
us.
just talking. So at the end, I looked at the cheat sheet in the back with Sarah, and I'm like, you know, we didn't really look for shrugging and, you know, but they had expressions in their faces, right? So they had an expression of joy or excitement or, you know, wow, this is a new thing. And we have the ball that we pass back and forth is like a very shiny ball. So they're like, wow, look, that's for, you know, so that you would just see excitement. There was at one point where one of the kids who didn't want to really participate so much in the reading went to his mom and tried to check in with her and be like basically all done kind of deal. Um, so so yeah, so I think we saw a variety of verbal and nonverbal communication and interactions. And I one of the things that we reflected on afterwards, because we sat down, we went to kind of fake score the Cars 2 with them. And we're like, well, this is really easy because they're all, you know, ones. There was one that when we gave a 1.5 when they weren't really, you know, didn't do it on the first try, or it took a little extra to engage them in the reading, for example. And like this would be much harder if this was not all ones. So
So a few points to make, and then we'll see. First of all, so great that you guys like did this. This is really how you start to learn about this stuff. It really is by practice, practice, practice. A few points to make that I want to just about things you were saying. Number one is, you know, you're seeing the little, we're training you to with the little kids, right? And a lot of those kids will have some language delays, but you know what? I see a lot of kids with autism who are very verbal. So,
I,
you know, so you have to be careful
so
because
one
you
of the
can,
things, yeah,
yeah.
one of the things that we talked about that we had noticed with patients in the past is like these kids were friendly, but they didn't come up to your into your space.
Mhm.
Um, and they weren't like so friendly that they wanted to, you know, look at a piece of jewelry or a piece of clothing of yours, which I've had autistic kids do before, where they want to like take my stethoscope from me, kind of thing. Um, and we also like talked about there wasn't like echolalia or any of those sort of more, you know,
So it's
atypical.
the quality of the language. It's
Yeah,
how is the language directed and used in a social way.
yeah,
The kids who tend to, like, you know, as you say, kind of get in your space, and they're coming up and they're touching your necks. They're often doing it without coordinating eye contact and affect. They're just kind of, I'm interested in your necklace, but I'm not really kind of associating as being part of you and something where I need to check in with you before I touch that. So I think those are exactly the other things. The second thing I was going to say is, you know, when you see neurotypical kids, there are kids that will do stuff and you'll be like, well, that's a 3. And I always say this: code what you see, don't interpret it, code it, just code it. You know, there are neurotypical kids who are going to flap. It's going to happen.
Right.
Okay, if you were scoring the cars, that will give you a 3, because we said when you see an, don't explain it away. Oh, but this is normal for kids this age. If you see a kid who's doing it enough, there are also kids who can be just neurotypical kids who can be extremely rigid with transitions. There are, I mean, all toe walk, there's a small group. I mean, there's, just code what you see. Don't explain it away. If you explain it away, you're gonna underscore kids. You're gonna miss them because you've kind of decided that this is what you think they are. So I sort of appreciate the point. And the last thing I wanted to say is, and I know you know this, but I'm just going to make the point. You know, the book, it's an interesting comment. You know, the kid doesn't want to read the book. The task, you're not scoring a task. I look like I'm frozen. I look like I'm in the middle of a weird expression. So let's see if I can. That's weird.
We can
Hopefully
hear
it's-
you. Your
I
video.
know, but look at that. I look like a, it's very strange looking. I think I'm about to lose you guys. So if I do, I'll be back. So I'll turn the video back on in a second. Anyway, the book, it's not a task of whether you can read the book, that we don't care if you look or like the book. You're allowed to hate the book, but you're allowed to hate the book. The task is not, are you successful with? But in fact, there's a lot of kids who are going to look at you and be like, no, I don't want to do the book. And their affect and their eye contact and all of it, or they're going to look at their parents like, do I have to do this? That's what you're coding. Whether you like or don't like the book is irrelevant, right? Just like any of the toys, what you do with them, whether you're successful in putting things, for instance, in a shape sorter, is irrelevant. It's not what is not a cognitive test. All right. Well, that was awesome that you did that. So other people, did anyone else, you know, dip their toe in doing structured observations this week or last 2 weeks?
Kristen Lynch and I just did one today, actually, which was really fun. It was one of my friends who has a 20-month-old and also came to our behavioral health space that's in a building separate from where we do our shots and medical exams. And so it was a nice first attempt.
So how'd it go?
I think it went well. I think one tricky thing is I know them socially, and so Annie, the little girl, came in and gave me a big hug. And so I think that was something, and the next time we do it, we'll try to find somebody that I don't have a pre-existing relationship with. But yeah, it was challenging to keep in mind all of the different things that I was supposed to be looking for. So I did feel a little clunky going back and referencing the cars and trying to remember, okay, what are examples of this? But it helped a lot to take notes. It was a luxury having Kristen Lynch there as well. There's a little bit of a, security blanket of just having someone else who's going through this for the first time.
So 2 comments about that, Kristen. So it doesn't matter to me that the child knew you. This is not a real evaluation. So she knew you and she liked you. In fact, what you're looking at then is, how did she communicate that with you? And then when you're playing with her, what was that like? It just was probably a more intimate experience than if it was a kid you didn't know, but it doesn't matter.
Yeah.
The other thing you just said, which made me think of something, is it's really helpful before you do your cars. And I'll tell you why in a minute. Before you do your structured observation, is to look over the items on the cars. Like, just get yourself in the habit of looking those over, because it reminds you of what you're going to be coding for, which reminds you then of what you should take notes on. Otherwise, sometimes you take notes and you're like, oh, wait, I didn't actually, put shapes in the shape sorter. Oh, where do you code that on the cars? Oh, you don't. So, if you look it over, it kind of, we I don't know if it's pediatricians or clinicians or I don't know what, have a real tendency to leap towards interpretation of what we're seeing. Oh, that's normal. That's normal. And I think part of what we're learning here is to put the brakes on that and just collect the data and let the data speak for itself. And then you make an interpretation. But it's so ingrained in us to just be very quick about making a determination. And so, I think what you were just saying about going back and looking at the cars, just sometimes looking at it beforehand. The
Mhm.
question of, is it mandatory to videotape? It is not. But if you want to, and you want to send it so that I can look at it, I am happy to do that. And I think anyone who has is willing to do that, believe me, it won't be a terrible experience because many people are very intimidated at the idea, like, oh my God, my first time doing this and I'm going to videotape it. But it's usually can be pretty helpful, I think. So you don't have to, but I offer it to everybody. And I think, was it you, Stuart, who did have some videos? Did you? Right. And send them. Well, I'll look at them. I'll show them to everybody here. No, sometimes we do. That's not true. Sometimes we do, but only with permission. If sometimes like they're really good and they're really worth showing to your colleagues.
I think you sent them via the file transfer, Stu, so I'll
Yeah, I
send them
did.
to Carol. So if
Yes.
you just keep an eye out, Carol, due to the size, it'll be a secure file.
Okay. How did those go, Stuart?
It was actually really interesting. I was fortunate enough to line up for relatives of people from my practice, and actually just did this last Wednesday. And there were varying ages from a little over 18 months to just under 3.
Oh, that's
So,
awesome.
so it was really interesting to see just sort of the differences in how in different ages they engaged. The youngest of the 4, basically, as soon as he hit the room, just bawled the entire time and took a long time to sort of settle down. And he separated from his mom. And occasionally, what was really interesting, also with this patient, is his 3-year-old sister was brought along as a tag along, and she has an ASD diagnosis. And so for a while, she was just sitting in the stroller, and then the mom asked if she could let her out. And I said, sure, by all means. And just seeing how, even though the 18-month-old was crying, 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 if I called his name, he stopped and he made eye contact, and engaged, albeit briefly. But the 3-year-old, who was on the spectrum, no matter how many times I called her name, she was just into the toys and playing and couldn't be diverted either way. Um, and there was like I said, so there were four kids, and there was a range in terms of how verbal they were. The last kid I did was just a chatterbox, and we had some really great interactions. And it was like, just like you said, purposeful language, not just talking for talking's sake. In the room, there was like a little castle that was on top of a bookshelf, and he just grabbed my hand and said, "I want that." That type of purposeful expression. And as soon as I pulled out the bubble wand, he was like, "I'm doing the bubbles." I'm like, "No, you're not." And he kept on. And when I went and said, "Ready, set, go," and didn't do it, he shot me a look like, I put something through his heart. So it was really, very instructive, and I really feel like I learned a lot just having that variety of age ranges and kids with level of engagement. I'll echo what the prior person said. None of them were interested in sitting with the book once they had the toys around, but I did videotape them, and when I went back and looked at the videotape, I realized that there was a lot more engagement, even though they weren't happy about me reading the book to them. They still, there was eye contact. They were looking at the pages. They were watching me turn the page. They were looking at the expression on my face as I was reading, which is stuff that I probably wouldn't have picked up if I hadn't done the video.
Yeah, those such great observations. And I mean, yeah, those were some really nice points that, you can see a range of behaviors. Quiet kids don't make you autistic. Grouchy kids don't make you autistic. Sometimes it's harder to do a good assessment, but the range of the breadth of what is kind of under the umbrella of neurotypical is pretty big, And so when you start focusing your lens in the way we're talking about, you see a real range of behaviors, and it is what makes it sometimes a little difficult to make this diagnosis. And you'll see as you do this, there's going to be all these kids. You're like, little of this and a little of that, and it can be a little challenging. Julie, do you want to add anything about any of the observations that people shared?
No, I mean, I give you all a lot of credit, right? It's hard to do this in the first place. It's really brave to record yourself. So, yeah, great efforts. And I would say just that 18-month-old we want to revisit given the family history and how they reacted.
Yeah, even the mother said she sees such a difference in, she said that his behavior that afternoon was not typical for him. And that, she recognized, the 3-year-old was nonverbal at 12 months. And she recognized, she sees the difference, and she's not a clinical person. She's one of our lab techs. But definitely sees a difference in the development from very early on.
Mm-hmm.
Yeah. So good job, everybody, like being creative and getting, jumping in. And that's, and if you don't have little kids around that you're able to practice on, do snippets during your well child visits. Just do snippets, like look at the structured observation. Just do one thing during a well child visit with a neurotypical kid. Remember, we're not doing evals now, but don't let it hold you back if you don't have a kid to do a full structured observation. We do really want people to do at least one before you do it with patients, because you don't want to be doing this the first time. And for the people who have done this, can you see why practice would be helpful before doing it with a patient? Yeah. I mean, you wouldn't want someone to be doing something the very first time on your kid. And I think we want to not do it in the same way, but the practice it gets smoother and better. So just keep going. All right. Should we go on? Anybody else have anything to add, or we can kind of jump into our subject matter for tonight?
Could I ask a quick question? I finally got to do it. Can you guys hear me?
Yeah. Yeah.
With one of our nurse practitioners brought her 2.5-year-old to my house this weekend, and we did it on Saturday. And I guess I left it pretty freeform. We set up a bunch of old toys that we had in the house around the living room and let her go and choose things. And she was a little more self-directed than I would have expected. She found the doll in the bottle and had to feed the bottle to the doll over and over and over. And she really didn't want to move on to other activities. She just started kicking her feet and pounding her fists on the floor when we told her she had to stop touching something and move on to another activity. And then she'd take the bottle and use it with the other stuff. Instead of a bubble blower, I had a marble run. And first try, I said, ready, set, go, and drop the marble. And she wanted to do it with me and drop it, but she understood. She had to say go or we couldn't drop the marble. And then she'd block things off with the bottle. And then she would feed the bottle to the toy frog. And then she would put the baby to sleep, as well as feeding the bottle to it, and brought it to her mother. And it was interesting. There were some things she loved doing, and it was really hard to get her to look at us or to choose to do something else. I was like, this is one I might have had a little trouble figuring out. Was she too self-directed, where I should be thinking of the autism diagnosis, or not? Or is it a stubborn personality, just a strong-willed?
Julie, you want to comment, and then I'll comment.
Yeah, so Mary, when you're talking about how self-directed she was and repetitively feeding the baby doll, and you were trying to redirect her to something else, was she looking at you and directing her like, I'm not going to do this, lady? Or
she might have been looking at the doll she was feeding. Eventually she would put it down, and she did come and play with the frog, and she immediately could do each thing that I wanted her to, like to say ribbit and to have it jump. And then we had another toy food that you cut apart, and she really liked that, and that was one of her favorites. So I could get her to move on.
Yeah, so it sounds like she was probably a little sticky, right? With a lot of effort on your part, you were able to direct her from one activity to the next.
I guess I would also add to that. Oh, sorry.
No, go ahead. No, go ahead.
I would add to that, I would ask the mom, first of all, is this representative of what she's like, and Did the mom think this is what she's like? And has anyone ever had any, first of all, any concerns about this kid or no?
No, no
Okay.
concerns. Mom has a little girl who just turned 5 and said their personalities are very different. The 5-year-old, if she were doing this with me, might have been too shy to engage. And this one is pretty stubborn about doing what she wants. But there was good language too, and definitely expression changes. When we did the marble run, she would look at me and laugh. And
So
smile.
the 2 points I would make for this are the following. Number one is neurotypical kids can be very self-directed sometimes, and they can be very stuck on what they want to do. And you see what you see, and but you can see when there are kids, they get very absorbed in what they're doing and they do not want you bothering them to change and do something different. And there's, but you have to look for all the other, the whole purpose of, just to say, of these structured observations is to offer children in a number of different contexts kind of communicative temps. That's really what this is about, in structured and unstructured way. The free play is to say, when you leave a kid to themselves, what do they do? How much do they try to get someone's attention and bring them in and share what they're doing? And then when you set up other kinds of things, back and forth play, the book doesn't mean anything except that it's just an opportunity to another opportunity that if the kid likes it is going to engage around that. So that's all we're trying to do, is set up novel, different circumstances to give kids an opportunity to see what their social communication looks like. And so, in the midst of a very stubborn kid who wants to do what they want, you want to be looking for all those other clues. Do they direct gaze towards you? Do they shift in their affect? How well integrated is sort of voice and body, meaning gestures and affect? Is it well integrated or is it not? Is there something highly repetitive about it? That's how you sometimes suss out the difference between kind of a more I don't know what the right word is. They all sound so pejorative to say oppositional or stubborn, feisty kid with a kid who's on the autistic spectrum. And you know what? Sometimes it's hard to tell. But I think that's a really interesting kid that you're talking about. What did the mother think by the end of that, by the way? Just out
The
of
mother,
curiosity.
so quiet and zen. She didn't say anything. She just thought it was interesting watching and made that observation that her sister would have done very differently.
Sometimes people appreciate when their kids are sort of feisty like that. And sometimes they feel like, wow, that kid was kind of a pain in the neck to this nice, doctor who was trying to do this, and they were very non-compliant. Parents like when their kids are compliant usually. I don't know. It sounds like
Yeah.
it was interesting. I mean, I think it's
Yeah.
actually really good to see kids. Presumably this is a neurotypical kid, but it's really good to see kids who do things that you are utterly not expecting.
Right.
To understand the range of what it looks like, that you can this test is not about compliance. I just want to make that point, probably have already, but this is not about sampling compliance. It's about looking at social communication. So honestly, the kid could be completely non-compliant with what I want to do, but if they're looking at me and they're smiling and they're provocative and they're gesturing, well, I know you're just doing your thing, but you're not, it's not autism. So we're not here to sample compliance. Just remember that. Excellent observation. Thank you for sharing that. All right, let's move on, Julie. What do you think?
Sounds good.
I think we have, sorry, just one slide about the cars 2 ordering. I don't know if John or Carol, either of you want to speak to this, or I'll pull it up. Or I can.
Sure, yeah, no, I can do it. So I think we shared with you guys the website for ordering the Cars 2 kit previously. It's what we had sort of seen as the most comprehensive package to buy. But maybe some of the more astute and I'll say frugal amongst you notice that we are not going to address some of the things that come in that kit. And so it is technically possible to purchase only the things that we will be addressing, which is the Cars 2 worksheets themselves and the manual on sort of how to score it, which is really a great reference for anybody who's flipped through it. You probably have seen it has some really great examples and just walks you through sort of step by step. So, if you want to see the full breadth of what the sort of Cars package is, you can buy the kit. but it is technically a little more economical to purchase only the 2 things that we think you need for for the purposes of these visits. Just to be totally sure, the thing that comes with the kit, in addition to the CARS 2 itself, the standard version is the high functioning version, right, guys? I think that's right. And also the parent questionnaire, the questionnaire of the parent or caregiver, I think it's called, the QPC. And so that is something that our previous group had found to be very helpful. And I think, Julie, you're going to speak to that a little bit later in the slides, but it can be a nice way to gather some of the history elements that are pertinent. And so for those who are thinking about administering a standard questionnaire to the parents, you may also want to buy the QPC. It can also be purchased individually, or it can be bundled in the kit. So we'll leave it to you guys to decide how you want to purchase them separately or together, but there's a little bit of cost savings when you pick and choose, I guess, a la carte.
Any questions about that before we turn over to some content?
I
Okay,
think
so
that somebody
okay.
did have a question, Nuria. Yes, that's correct. You do not need to purchase the high functioning version of the car. So if you're going to do the a la carte version, you don't need that one.
And the questionnaire we will be using,
That
it plus minus depends on what you want to do.
plus minus, yeah. Let me give my talk and then maybe that will kind of answer that question.
Oh, we got the kit. We got the kit. So I just was.
Oh, you have the kit.
Yeah, I've
Okay.
been just looking.
You have it. Oh,
yeah.
yeah. Let's talk about if you want to use it. All right, I'll share screen, Jane.
Yeah, we just have one more question in the
Oh.
chat. In reference to the CARS 2. The difference between number 1, getting their attention, and number 7, visual attention.
Number 1 is really about engagement. How engaged is the child? Visual attention is really 2 different things. It's a weird thing about the CARS. It's the same with the listening one. It's about, that's really looking at eye contact in particular, or else is there unusual visual regard? So 1 is really around how much does the kid, what's it like to engage with this child? Does the kid engage with you? It's not necessarily about eye contact. And 7 is very specific. Does that answer your question, Greg? Looking to see where you are. Oh, hopefully that answers your question.
Thanks, girl. Yes, Julie, I think we're good to go ahead and share.
All right, is everyone, am I good, Jane?
Yep, you're good.
Okay. All right, so I'm going to talk a little bit now about taking an autism history. I really kind of think of this as a bit of a step backwards from where we are, in the sense that you are all doing a fantastic job practicing your structured observations and practicing the CARS. But really, I think we can think about taking an autism history as perhaps a step before you do your structured observation to help add to the data that you have available. So no disclosures. Why do I need to do an autism history? And this first sentence is really a statement directly from the CARS manual, stating that it cannot be overemphasized that ratings from the CARS should be used as only one piece of a multifaceted evaluation that includes developmental history, review of prior evaluations, parent interview. Essentially, as Carol and I have been saying, we don't have a biomarker for this diagnosis. And so it really is incumbent upon us to use every data point that we have at our disposal to help make this diagnosis, right? An interview being one, a structured observation, the score on the CARS being another. As you all know, Even in the DMC, right? Carol and I are collecting intake paperwork from patients before we walk into that room. So, you know, we're walking in with data too, helping us to make this decision. And I think obviously this is especially important for patients that are not your own, patients that are being referred to you by colleagues, to have some of this background information. Again, kind of giving us this pre-test probability. I think you could ask anyone in my department after we review that intake paperwork that the patients have to send in, you know, where then is ASD on our differential, thinking about going into testing. There we go. So pre-visit information that you potentially have at your disposal, your own clinical level of concern, assuming this is your own patient or that of a colleague's. Perhaps you have some sense of the parent's level of concern. We're assuming that for most of these kids, perhaps they have an autism screener on board, either an MCHAT score or a READ-LT through early intervention. You might have a general developmental screener, a SWIC, for example. And perhaps some of these kids have already had an early intervention evaluation. And if that's the case, you have those reports. You perhaps have the IFSP, or the Individualized Family Service Plan, that EI is generating for the families. And then another thing that we can think about is the CARS questionnaire for parents or caregivers. So this is an option that at least folks from the first group, Dr. Angus, I know, is using this as part of her assessment. So that is yet another thing that we can talk about having. So the CARS parent questionnaire, or the CARS 2QPC, is a parent completed questionnaire. There's 7 sections in it. The first 6 sections are questions that are on a Likert scale. And then the last section is really more of an open-ended response style. It is important to know that the CARS parent questionnaire really spans the spectrum. So the questions are not necessarily geared only towards lower functioning kids, or, as we've been saying, more frank presentation. So keep that in mind. It is an unscored form. So there's no score involved. It really is just designed to help assist in the gathering of information related to the autism diagnosis. And it's designed to be meaningful to the caregivers. So the sections do not map directly onto the CARS. It really is recommended as a potential framework for you then to maybe develop an interview off of. And certainly at least also have the parents' observations going into an interview or going into your observation. So that is the heading. And then I know some of you have already seen it. We were going to have the copy posted, but this is what it looks like. And it is available.
Do you want me to share it, Julie, quick?
Maybe we can share it at the end if people are
Okay.
interested in digging into it a little bit more. That's great. Okay. So the other thing that we have to think about going into the structured observation for these kids is establishing a developmental level. We really want to make sure that we are only evaluating children for an autism diagnosis who are at least at a 12-month level cognitively. As Carol just said, the CARS is not a cognitive assessment, right? So we have to figure out that data as best as possible from other data points. You're going to need to rely to some extent on your own well-child check developmental milestones, helping with this. If the child has gone through an early intervention assessment, most of those assessments will include something called the Battelle Developmental Inventory, where you will get a table similar to one here. Or at the very least, they try to do a cognitive and an adaptive score. So on the child here, we see that in the cognitive domain, they have a developmental quotient of 85. These are standard scores, so they are a mean of 100. And then almost always early intervention reports the age equivalent. So in this child, there's an age equivalent of 22 months. So we feel very comfortable proceeding. Okay. I'm now going to generally just walk through how I would take an autism history. Obviously, you're going to adapt this to your own flow, your own style, your own time constraints, the ASD template available to you. So when I start with a general HPI, one of the in a child that I'm concerned about autism, probably the question I start with is asking the parent, when did you first have concerns about your child's development? A common response I get to this question, I feel like, is that parents will say, oh, up until about 12 months of age, the child was doing extremely well, hitting developmental milestones. I had no concerns at all. And then somewhere around 12, 15 months, all of a sudden they lost all their words, and now they're not saying the words they used to say. So if at this point the parent is describing this potential language regression, I do tend to ask about other potential regression, specifically in a motor domain or in an adaptive domain, because I would say that regression in other areas like that is not necessarily consistent with an ASD diagnosis alone, and we really need to expand our differential if that is the case. I asked the parent, what are your concerns? This is one place where if you know the family really well, you may want to say, is autism a diagnosis that you've thought about? But there's another place later in the history that I also ask about it. Here's where I also ask, what services is the child currently getting? Is early intervention already involved? And are private services already involved? So, and when I say private services, I mean, for example, speech and language therapy through medical insurance. Here's where I also ask about who cares for the child during the day. Is this a kiddo who's in daycare and exposed to a lot of kids routinely? Is this a small home daycare? Is this a center-based daycare? Are they cared for by grandparents? And then asking, what is the primary language that this child is exposed to for most of the day? And again, if you feel like this is a point where you can ask the parent, is autism something that you've thought about for this child, or if it's too early on, there's I also ask later in the history. So after my HPI, I then delve into a pretty detailed section about language and communication, because as we've sort of alluded to, many of the kids that we're seeing at this point, right, perhaps the two things you're trying to decide between are, is this a child on the spectrum versus is this a child who just has an isolated speech and language delay? So I do feel like it's pretty important to spend some time on this section. I usually start with the little kids by just saying something like, how does your child communicate with you, right? For younger, nonverbal or minimally verbal kids, you often hear something like, oh, he takes my hand to what he wants, right? Or he brings me what he needs, right? He brings me his empty sippy cup when he's thirsty, or he brings me the remote control when he wants the TV on. If you have a child who is a little bit more verbal, you can ask questions like, approximately how many words or word approximations do you think the child has? Sometimes at this point, it's important to get around whether these are words or sounds, right? So sometimes parents will say something like, oh, he says mama and dada. And when you really delve into it, those words are not specific to the parents, right? Those are sounds. but not words specifically meaning their parents. Does he put words together, right? So if you have a child who's communicating, who has words, who has, decent vocabulary, are they putting those words together? And if so, how flexible is that language, right? Are you having a kid who always has to say something in the exact same way, such as kind of maybe labeling the color before they say the actual object, right? And I would really spend more or less time on this section, depending on, at this point, how concerned you are versus for a diagnosis of autism versus more of an isolated speech delay. Obviously, we do want to get at receptive language a little bit. Getting at receptive language for really young, perhaps lower functioning kids. Sometimes I will start with a question as really getting at safety concerns, right? Do you think your child understands the meaning of no or stop, right? Are they able to respond to those words, or are they responding to the tone of your voice? Other questions in this section: does he understand words they use routinely, such as dinner time or car or outside? Are they able to follow simple one-step commands? And are those commands, are they following a gesture with the command, like come here, versus just the language of come here, right? And then receptive language for a kid with more skills could be, are they able to, where's your nose, where's your ears? And are they able to indicate objects in a picture book? Where's the ball? Where's the car? All right, so I bring this next slide up. I know that we've seen it 100 times at this point, but I bring this up because I then organize my autism history by DSM diagnostic criteria. So I thought it'd be really good to sort of just put this slide up for 1 minute, reminding ourselves that for social communication deficits, we have to meet all a criteria in all 3. And then for restricted and repetitive patterns of behavior, we have to have symptoms in 2 of the 4 categories. Because my history now really takes the structure of the DSM symptoms, and I don't always do it in order. So I do usually start with the social communication domain, but I start with A2, deficits in nonverbal communication, not A1. So I usually will say something like, especially if I have kind of a minimally verbal kid, say to them, tell me about the gestures they have. Do they point to make requests? If they point to make requests, are they also pointing to show you things, right? To direct your attention. Oh, look out there at the snow. And what other gestures are they using? Do they nod their head yes and no? Are they clapping? When they're clapping, are they making sure that you're clapping too, or are they clapping in isolation? Another common gesture we ask about is waving, right? Is this a kid who's waving to you, or are you seeing a kid who, yes, is waving, but it's one of those very atypical inverted waves to themselves? A very atypical form of communication that you will sometimes hear about is something called hand as a tool. Hand as a tool is something like, and I usually phrase it, does your child ever use your hand to get things done, right? Use your hand to reach into the diaper bag to get something. Use your hand to manipulate a toy. That's a really atypical nonverbal communication. I don't think there's any one thing pathognomonic to ASD, but certainly there is at least one psychologist in my department who, if she sees this, it's almost as if there's no going back at that point. That's how atypical we view that. In A2, deficits in nonverbal communication, you definitely want to be asking about eye contact. And that's really probably where I end for the younger children. There's certainly other things in this category, like shared facial affect, vocal prosody, integration of eye contact, gestures, and vocalizations. But those are harder things to ask about, and so I think generally lend themselves better to being observed. All right, so after gestures, I usually go on to asking about play. And so for A3, developing, maintaining, and understanding relationships, I usually get at that section by saying, what kinds of things does your child like to do or play with? And in that, or the answer to that question, things I'm looking for are, is that child beginning to demonstrate symbolic and imaginary play? So Mary's kiddo, right, who's feeding the baby doll. Or are you seeing more repetitive atypical play? Do you have a parent who's describing to you, oh, it's the same thing over and over, or they're lining up the toys, but then they're not really playing with them? If I get really atypical responses to this question, so a parent who says they're not interested in toys, or all they're doing is lining them up, or it is really repetitive, I will sometimes jump to the RRB category at this point. But if not, I keep going in social communication. One question we want to get at this section certainly is, how does this child interact with other kids their own age, right? And so things, you know, where is this child during the day? Are they in daycare? What do you hear about their interactions with peers at daycare? If they're not in daycare, how are they interacting with siblings? Or if this is a only child, asking something like, if you took them to a playground, how would they interact with other children there, right? Is this a child who is both initiating and responding to social bids? And so then, last but not least in social communication is our A1 or our social emotional reciprocity. Things to ask in this category include response to name. When you call your child's name, how frequently do they respond? And if the response to that is not frequently, you may need a follow-up question like, is there something you need to do to get their attention, right? So if it's, how would a parent get the child's attention if they're not responding to their name? Do they have to make a sound? Do they have to sing the name? Are possible examples. Other questions in this domain: does he like social games like peekaboo or hide and seek? Will they imitate behaviors? Will they imitate facial expressions like a social smile or sticking out your tongue at the kid? And then referencing the caregiver. How frequently do you feel like your child is checking in with you, right? And is this checking in or referencing for safety purposes, or is it sharing enjoyment with the caregiver? Questions about social communication criteria before I move on to restricted and repetitive behaviors? Okay, I'm going to keep going then. So restricted and repetitive behaviors, with B1 being stereotyped or repetitive motor movements, use of objects, or speech. I usually open this section by saying something like, does your child demonstrate any behaviors that worry you or that you don't see other children do? Sometimes that gets me where I want. And sometimes it doesn't. Sometimes the answer to that question starts to go down a path of they're a picky eater, or they're not sleeping, or they throw a lot of temper tantrums, which is all stuff I want to hear and all stuff I want to know about, but not what I need to know for this domain. So if that happens, I will redirect by sort of saying, okay, I want to run through a list of symptoms that I sometimes see kids do, and you let me know if you've ever seen your child demonstrate these things. And then I will literally go through that list, usually demonstrating them as I'm going, because I feel like parents can often say, oh yeah, I have seen that. So I'll literally go through the list of, do you see your child hand flap frequently? Are you seeing finger posturing, right? Do you see a kid manipulating their fingers by the side of their eyes or down by their side? Is this a kid who is bouncing or jumping repetitively in place? Do you ever see your child spin themselves in circles or spin other objects? Are they spinning wheels repetitively, perhaps with unusual visual regard, right? Watching those wheels spin. Is this a kid who's lining up objects, be it toys or food or household items routinely? And then also in this section, atypical language, especially if you have a child who has enough language for it to be atypical, we want to ask about that, right? Certainly the more common forms of atypical language in less verbal children could be things like echolalia, directly repeating something, singing to themselves. We often hear this, right? The kid really likes music and they are singing, singing, singing constantly, but they're singing to themselves. They're not singing with others. Or also repetitive vocalizations, and very classic ones include sounds such as digga digga or ticka ticka, very unusual repetitive vocalizations. Okay. So then to B2, or adherence to routines. And here we're getting at kids overly upset by transitions or overly strict adherence to routines or rituals. These are the kids who get unreasonably upset if you drive a different way to daycare or to the school. I think we see this more so in older kids than in younger kids. And depending on what other symptoms you're seeing, anxiety can also be added to the differential if this becomes a high level of concern, right? Kids who are so strictly adherent to their rituals that any minor change really throws them for a loop. I will say that this is an area for younger and lower functioning kids that if I already feel like I am easily meeting criteria in 2 other domains, I might skip this, right? Or not spend a lot of time on it. So then B3 are restricted or fixated interests. Here we're looking at really excessive interest in typical or atypical topics, right? And so I'll usually ask this by saying something like, is there anything that your child seems to be really interested in, almost obsessed with? And I'll say some kids I see really, really like dinosaurs or trains or wheeled vehicles, and see what the parent says. Often in younger kids, some of the, I would say, more common restricted interests that we see have to do with these pre-academic concepts of letters or numbers or shapes or colors. So I would be on sort of the lookout for hearing about these things. This can be challenging, I think, because parents are often view this as a strength and often are very proud to say, oh, my child isn't responding to their name. They don't call me mom, but they can recite the alphabet and they're pointing out alphabet letters wherever they see them in the community, right? That's atypical development. And so that is sort of a preferred interest that kind of we want to ask about sometimes. Then unusual attachments to objects or topics. And for the little kids, I think, it's often things like they want to carry something around in their hand all the time. And this is something I miss in my own observations all the time. I feel like an hour can go by and all of a sudden I didn't realize that a kid has, got something in their hand and they've had it there the entire time. You'll often hear parents say that for whatever reason, it's sort of small cylindrical shaped objects that the child wants to hold. But all those would fall under restricted or fixated interests.
I have a question. Some
Yeah.
of these things seem like they could also be positive in people who have in kids who have other issues, right? Like, so sometimes if you have somebody with anxiety, they might take on something and carry it with them everywhere, or maybe sing to themselves to soothe themselves. So I don't know. I mean, I'm not a developmental pediatrician, but it feels like this overlaps with a few other things too.
Well, I think this goes back to, what Carol and I have said, you're going to see some of these things in neurotypical kids, right? Or in kids with another diagnosis. And that's part of the reason for getting all of this, right? You will absolutely see neurotypical kids who hand flap. Yes. And I think that's right. You will see kids who are anxious who are holding on to something, and that's, a coping support for them. Absolutely. Yeah. It's the whole overall picture, right? So finally, restricted repetitive behaviors, B4, are the sensory category. Usually by this point in the interview, I would say parents have brought this up as a concern. But questions you can ask are there any sensory things that seem to upset your child, right? Such as certain textures or loud noises. These are the kids, right, who are walking into your office already covering their ears. Or the parents say, right, I cannot get a certain texture on them. Alternatively, right, so those are the sensory things that upset the children. Are there any sensory seeking behaviors your child seeks, right, that they demonstrate, such as we see kids who are very attached to rubbing a piece of soft cloth or something on their cheek. Other sensory seeking behaviors are unusual visual regard. Do you ever see your child, avert their gaze to look at something, right? Hold something really close to their eye, or really change their eye gaze to look at something either really close or really far away? These are the kids who sometimes will literally just lay on the ground, right, and roll a car back and forth in front of their eyes, watching those wheels roll repetitively. And then mouthing objects, I think, falls in this category. Is this a child who is mouthing or licking objects out of the context that is appropriate for their developmental level? All right, so that's our DSM criteria. Questions before I keep going?
Is there a difference between the anxious kids who have OCD and line up their toys versus someone with autism who lines up the toys?
Yeah, I would say a couple of points to that. First of all, I think diagnosing OCD in the age group you're looking at would be so rare that straight to psychiatry, right? That would be pretty unusual. So I think if you see a young kid lining up their toys, ASD would be higher on my level of concern than OCD. And certainly, getting at OCD in a young child is pretty challenging, just because the hearing about their obsessive part, thoughts. But anxiety, I think sometimes kids who are ordering their lives like that, in an older kid, anxiety might be high on my concern list.
How much of a red flag is the letters, numbers, colors thing? Like if you have a kid who is, giving good eye contact, seems socially well related, but is really great with all of those things at a very atypical age, Is that something you need to be really nervous about? Because I have a few of those.
Again, it's the whole picture. I would say, what's their language like? If they're really that kind of precocious and advanced that their language is following course with those interests, then it's less of a concern.
Okay. Thank you.
Just sorry, Julie, but like, you know,
Yeah.
I think wondering, is it a splinter skill? Does it seem strongly out of character with the rest of the skills? So if you see something where you're like, wow, that kid, as Julie says, has not a lot of language or a lot of other things, seem very delayed, but then very strong. That, you know, are you seeing what looks like, again, a wildly deviating sort of profile in the kid? And by the way, a lot of your questions as I'm listening, you know, kids will line up their toys sometimes. Or if that's all they do, you know, I think that's what you were saying, Julie, too, right? I mean,
Yeah, it's not one thing alone, right? That's why all of these things that we're asking you to do are so vitally important, because you really need the whole picture, as many data points as you can collect to help with this. Okay. So family medical history, I think for many of these kids you're seeing, you guys probably have that more so than I do. But things that we want to know about, speech and language delays, general speech and language delays in family members. We want to ask about learning challenges, but really also getting at cognitive impairment specifically. And I'll often ask this question by saying, are there any adults in your family who can't live alone or need support to get through daily life, trying to get at, is there intellectual disability known in the family? Here, if I haven't already gotten a sense early on in the HPI, is where I will ask, is there any family history of autism spectrum disorders? And then I usually follow up that by saying, is this a diagnosis that you've thought about for your child? So that kind of, I use that as an opener at this point in the history to really get a sense of where the parent is in this process, and thus where I'm gonna kind of need to gear the rest of the evaluation. Then physical exam, again, you guys have probably done physical exams on these kids who are your own patients, things that we are particularly interested in looking at. Has the child had an audiogram? So this is something that early intervention is usually pretty good about ensuring, but not always. We want to make sure that the child has had a sound booth hearing test. And it is also something that probably, that I think in many patients needs to be followed over time, because there are some kids, especially the ones that I think people have alluded to earlier, right? The stubborn kids, or the kids who just, for whatever reason, can't comply behaviorally with an audiogram and will only get limited information. And so we need to follow that sometimes over time. Growth parameters, height and weight, right? And then head circumference for us really has implications, both in the differential and for genetic testing. For instance, if we have a kiddo who has autism and has macrocephaly, we're going to add P10 mutation analysis to our genetic workup. Arguably, if we have a child in front of us who has microcephaly and has pretty significant developmental delays, that might be a kiddo who, for whom head imaging would be warranted. Then skin exam. On a skin exam for these kiddos, we want to be looking for any unusual markings or bruises. Unfortunately, some of these kids may already be developing potential calluses from self-injurious behaviors or repetitive behaviors, right? You're already starting to see calluses on their knuckles if they're mouthing them or biting them repetitively. And ideally, we also want to try to be looking for neurocutaneous stigmata, such as an ash leaf spot associated with tubular sclerosis. I find a motor and neuro exam really hard in these little kids, right? They don't want to comply with that, but to the best of your ability, right? As much as you're able to get reflexes, look at symmetry, look at how steady they are on their feet, looking for toe walking, etc., is helpful. And then obviously any dysmorphologies that could make looking for a genetic syndrome higher on something that we need to do, right? Things like hair whirls, ear positioning, facial symmetry, palate, palmar crease, or hand or foot abnormalities. So then all that is done, right? And we've, at this point, do we need to do a structured observation, right? At the end of collecting autism history, perhaps you have the CARS parent questionnaire that you've looked at. What is your clinical concern for an ASD diagnosis, right? Going into your structured observation, what is your pretest probability level of concern? Or after doing this, are there other diagnoses that are higher on your differential that you feel like you need to be thinking about? The other important point, I think, too, at the end of this is, where is the family in this process, right? How concerned is the family about an ASD diagnosis? Because that may really change how you do the structured observation or how you're speaking to the family while you're doing it. How much are you going to need to bring them on board during that process? And then I think sometimes cultural other barriers that need to be addressed come up when you're taking a history. Questions, thoughts?
I'll make one comment, Julie. Also, you could, if you want to not share, because I'll share my screen when I give this part of
All
it.
right, let me stop. Yep.
Yeah.
Yeah, better.
I was thinking about this while, that was so comprehensive, and it was, it just really speaks to all the pieces of information that we want to get. But I was sort of thinking about this, and even with some of the questions that you guys were raising is, we have this cluster of symptoms that we put together of social communicative deficits, restrictive repetitive behaviors, and all it is a list that is our best guess as to what this thing called autism is. But I can tell you, for every kid, for tons and tons of kids I see, kids do not comply with the DSM. And you will get histories right? Then you'll get histories where you're scratching your head. It's not, it would be nice if everybody gives you the positive history for all the different components, but I promise you, it will not always work out that way. And there are kids who have a lot of like those A symptoms and not a lot of the B symptoms. Some kids who present with a lot of the B symptoms, not a lot of the A symptoms. And just remember, that's not the limitation of the kid, it's the limitation of our understanding of this disorder. It's why you want to be, I think, incredibly careful about getting the history and being kind of meticulous, because we're doing just honestly, our best to try to figure out what the heck this thing that we call autism really is. But that's why I'm always saying, just record what you see and, ask the questions. But kids aren't always going to behave and have all the DSM criteria exactly as you want them to, but you will still feel like they have autism.
No, I think that's a good point. I mean, part of the reason I feel like I do rely so much on my history is because the child, I'm getting to see the child once, and the history, hopefully, right, with decent reporters, is what the parents are seeing day in and day out over a time period that lends itself to being very valuable information. But no, they don't read the book.
They don't read the book.
So I would say one other thing that as general pediatricians, right? Some of this history stuff is not going to be gathered at one session, right? We're seeing these kids over time. So we're going to have a little bit of a better benefit to just the history stuff over time. And honestly, I think that the kids that we're worried about and maybe going to do a structured a structured observation on are going to be the kids that we already have that history. We already have, maybe not in such a detailed format, but over time have kind of like checked a few of the boxes enough to make us think about this. Or if we're that unsure and don't want to do it, that's, at least right now, that's what we're doing. We're just referring those kids, right? You have that high index of suspicion because you've seen their development over a year and a half time.
Well, Ruth, I think that is the beauty of primary care, that you do see kids over time and you do have a picture. So you're not seeing just one, it's not one time point. That is the beauty of it, is that you're seeing kids over time. I think that's just right. And I would say, by the way, the kids that we're hoping that you're going to make the diagnosis are the kids who read the book and have all the symptoms. The kids who don't are the kids we should be seeing, because they're the more ambiguous kind of kids.
Julie, Carol, can I ask, so you said you sort of structure your history along with the criteria. Do you then sort of like make a mental map of like, yes, A1 through 3, B 2 and 4, and then take that into the observation differently? Or do you sort of just put that aside and do the observation and like know that you're, going to look at every kid the same way? Or are you going to take the history to look for certain things?
What do you do, Julie?
Oh, I didn't know whether that was for me or you.
Sorry, it's both.
Both.
I am thinking about criteria as I take the history, and then are there things that, I mean, I don't know that I'm then going into the observation saying I need to find this or this, like what's missing. But yeah, I certainly take the history thinking, okay, what do I think is going on at this point? But yet trying to stay as objective as possible until I'm observing the kid.
I think it's a great question, John. I don't think I do that. I think I just do the observation. Yeah, it's a great question. Like, I'm not specifically looking, but if someone has mentioned it to me, I do, I read my notes over before I do an observation of a kid, and I look to see, am I seeing what they told me? Because then I sometimes will say to the parents, you mentioned that they do this, and I'm not seeing that. Or I'm seeing a lot of this, and you didn't mention those things. Have you ever seen this before? So that's sort of how I use that. All right, I think I'm going to go on if it's okay, because we want to get to the role plays. And I see Jason is here. Hi, Jason. So we're going to now talk about giving feedback. Let me just share my screen and hang on a second. Let's get down to. Okay, hang on. There, can you see that?
Yep.
And you see the screen, the slide discussing findings?
Yep.
Okay, I'm going to try to do this fairly quickly because I do want to make sure that we end on time and that we have have time to have some fun with the role plays. So I'll start this by saying, talking to families and doing the evaluation. Sometimes people think, oh, that's the culmination. It's not. It's in many ways, it's the beginning of the journey that you're going to be on with a family. And so when you talk about those findings with a family and giving feedback, it's really important that we think about how we're doing this. I think we all often think, well, I don't know if I'm right about this, but I think sometimes we think we all know how to do this. This is very simple, and it's not. And I'll tell you, when people hear information that can be life transformative, and this stuff can be life transformative, you're potentially telling someone a diagnosis, and even when they know it, there's a fantasy that you're going to say, no, it's not that. So when you're having a conversation of that magnitude, believe me, when it goes to either extreme, if you will, really well, but definitely really poorly, people remember this. I can't even tell you the number of people who will come in and recount stories about like how poorly another evaluation went in the way that information was delivered. So the stuff kind of matters. It doesn't mean we're always going to get it right, but there are certain things that we can do to ensure a higher likelihood of that. And that's what we're going to talk about now. All right. So there is this process at the feedback visit where someone walked in the door suspecting a diagnosis and they left where the diagnosis potentially was confirmed. And there is a space in there where there is going to be a process for a family that may be a process of grieving and acceptance. And what that's going to look like will look different for every person. But something happens during that visit when you give a diagnosis where there's a change. Their life has changed a bit as a result of what you've told them. And I don't know how much you all are delivering feedback of that nature to families. I'm not sure, but I'd like to hear afterwards. When people have looked at, how did clinicians do when they were given an autism diagnosis, only half of surveyed families reported satisfaction with how that diagnosis was disclosed, which I think is kind of low. Now, maybe that's inevitable. Maybe when you're going to get a really important, serious diagnosis, people aren't going to feel satisfied or that it went well, but you do have to, we're going to unpack that a little bit. Okay. These are the kinds of feelings that people, when people have been surveyed of what was it like when you were given this diagnosis, these are the kind of emotions that people will experience. And, I guess what I would say is don't try to pre-guess how someone's going to experience or expect a certain kind of reaction, because people are going to be all over the place. And the two comments I would make is, number one, you can have multiple feelings at the same time. You can be sad and you can be relieved. You were worried for a really long time and now you're relieved at least that someone's given it a name, but you can still be sad about that. So you can have a lot of emotions going all at once. The thing that kind of bubbles up to the surface during the visit may be only one of the many feelings that somebody's having. And so you just got to let people, I don't know, sit with whatever they're feeling at that very moment. And just know, and I'm going to get to this, that sometimes strong emotions are going to be directed to you because you're the person who told them this. And I'm not suggesting that we should be, that people should be abusive to us, but I do think there's something about knowing that sometimes when you are the messenger, you're going to be the recipient of strong feelings that someone's having. So you may tell people something, but these are the kind of things that people are thinking about, even though they're not saying it or showing it. Will my child live a normal life? Will they go to college or have a job? Did I cause this? What should I tell my family? Is this clinician correct? And what now? Now, they may not share this with you, and I don't think our job is to extract all of this from them. It is a process by which people are going to come to terms with this and in their own time. But I think where our job is to create an environment where if they want to talk about these things and they want to ask about it, we have created a climate that's open and inviting so that people have an opportunity to talk about what they want. And I'll tell you, in a busy clinician office, particularly for I think, general peds folks who have lots of patients, it's hard to cultivate that feeling in the room that like, this is our space right now. And I would tell you, time is an important factor, but it's not the only factor. It's about creating a space where we are very attentive to what someone's telling us and we're not being distracted by other things and people aren't coming in and out of the room and blah, 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 phones ringing, texting, buzzing, blah, blah, blah. So I think kind of cultivating a space that says whatever you feel like you want to bring into this space right now is what I want to hear. These are some things to be thinking about when we think about how to construct our feedback visits, the timing. And that has to do with, are we doing it all in one visit? Are you breaking it up? What part of the day is it? Who's at the visit? Is the child there? There are times when we will give feedback, especially with young children and the kids are present. It makes a difference. It's not necessary that with very young children that they're understanding it, but they may be extremely distracting to the parents. And you just have to find out, is this, do you want to find a time to do this when you don't have the kids present? Is this in person or by Zoom? I do a lot of feedbacks these days by Zoom. I still would rather do most of them in person just not always realistic, but I'd rather, there's something to me about sitting in a room with somebody that feels different than doing it by Zoom. But, you know, if I see people who are coming from very far away, you just have to bridge that. But it's something I just think about. And then what might be the cultural considerations as we're speaking to families? Really, what are they hearing? There have been studies that looked at, like, you know, what we think we say, how satisfied someone is with what they heard, and that they often, there was a study, it was in Australia, and where they feel like the clinician thinks they're saying something, the parents just didn't hear it and were upset because they didn't hear it. So just know that what you say we have to check in, and I'm going to get to that, because we think sometimes we're saying things, but it's not always what parents are hearing. Okay, so this was in this Australian study that many parents reported not hearing about school supports, how to discuss a diagnosis with the child, an ideal therapy plan, and satisfaction is increased when parents can ask questions, leave with written information and resources, and that a follow-up visit is offered. So to me, the second part is the most important, because there's a lot of things you can talk about. Honestly, I think if we overwhelm people with too much information, I'm not sure that's so helpful. But people don't want to feel like you're telling them this information and you're kind of leaving them out there to figure it out themselves. So saying, you know, this is just the beginning of a conversation, and leaving room, budgeting time for people to ask questions and have conversation, push back on what you've said to them, and giving them some kind of either a written report. I don't usually have my written report done by the time of the feedback. I actually like to do the feedback and then finalize my reports, because sometimes things come up that I want to add. But you really don't want to lag for too long without giving somebody some written information. I'll tell you, just as I was sort of looking at this and preparing for tonight, I was thinking to myself, you know, there's all these companies that are opening up that are doing these like virtual evaluations, you know, all over the country. And I think they, you know, on one hand, they, you know, they help kids get a diagnosis early, but I do think there's an awful lot of times where they just are not following kids. And I think a lot of families are going to end up feeling kind of, I don't know, it's a one-off, and they're feeling, I don't know, a little bit, I'm not sure it's quality care when we don't really have a means by which we're following kids, and they sort of just often turn it back to you guys in primary care. All right, so these are sort of some of the components about doing a feedback. You know, some of them are sort of obvious, but I think it is helpful to establish that this is about shared decision making. I sort of skipped down a little bit, letting people know what you're going to be trying to accomplish in the session. I always start with reviewing what I did, describing. I always make sure I include things about children's strengths. And it is remarkable how sometimes it just so easily can move into only areas of weakness. And I just think it's really important for parents to hear us talking about the things we appreciate about their child. And then we want to state the diagnosis and state it clearly. You know, I'll tell you, to me, it's a kind of a delicate a dance a little bit. Like on one hand, I always sort of go in and I ask them again, let's go over why you came to see me in the first place. For you guys, this is it is still relevant, because you're going to say, let's go over why we did this in the first place, and a little bit of what they told you, not the entirety of the history, but a little bit to say, why are we here today? And you know, I always review a little bit about what I saw in the child, and I do that so that I feel like I want to make sure that we're in sync about it. Like what I saw is sort of, you know, their understanding of who their child is. But if you take too long to get to what the diagnosis is, people are like, can you get on with it already? I want it, like, I'm waiting to hear. So it's kind of a dance. And believe me, I've seen clinicians do too much on either end. I saw a clinician who literally within a minute of seeing the family said, yes, we think this is autism. And the parents were like, whoa, wait, what? And I said, you got to wind it back a little bit. Like you kind of have to do a little of the groundwork before you just jump in with that. At least that's my technique. And I will tell you, everyone has their own way of doing this, and maybe Jason and Julie will chime in on that, but everyone has their own rhythm and style, and you have to find what that is. But just keeping some of this in mind, I think, is helpful. Okay, when we give people the diagnosis, I think it is important to be clear, to be honest, to stop and pause, to not go on for too long without giving people a chance to digest, to ask them, are there any questions? Is there anything confusing? Do you need some clarification? Check in on reactions. And I caution about giving too much or too little information, somewhere between every single thing that's going to happen for the next 20 years. And here's the diagnosis. See you later. Something in the middle of that. And different people want different things. When you're doing feedback with families, you just have to be prepared that you may get difficult questions. You may have strong reactions. I think it's our job, honestly, to be able to sit with those in a way that's empathic and is not kind of shutting people down around that. We have to be open about uncertainty, that there are kids you're going to see where, first of all, where we don't know exactly what a kid's going to look like. People will ask you, I see little kids. You will see little kids, and they're going to ask you, maybe they have with kids who already have a diagnosis. Well, is he going to go to college? I don't know. I don't know. But I also think I see people dodge questions that they should be able to answer as well. So, being clear, but also not, recognizing you can't answer everything. Don't be afraid to say, I don't know. And make sure that you discuss the relevant diagnoses and outline recommendations and help families prioritize the next steps. Because a lot of families, they really don't know, what should I do next? That's what I want to walk out of here with a plan. And you want them to walk out of there with a plan as well. Don't overpromise. Don't overpromise. We want things to be okay for people. We just do. It's our nature, I think, as pediatric providers. It's just the kind of that we want to make them feel like it's going to be okay. It's going to be okay. He's going to be great. Don't overpromise things. You can be quite compassionate without overpromising, but it's a tendency, especially if you have a parent who's very upset or is tearful, that we're going to want to make it better. And there's ways to help and be incredibly compassionate without overpromising. So just be aware of that. There are going to be challenging circumstances, and we're going to try to tap into some of these during our role plays. You're going to have parents of very varying abilities, education, parents with their own disabilities, different kinds of coping styles, non-English language speakers, where it's much more difficult to kind of get a sense of their reaction and understand their questions. People who come really late and you've only budgeted a certain amount of time. Parents who disagree, who argue with you or with the spouse, they undermine each other. Argumentative parents who are, again, arguing with each other, arguing with you. You're running late, you're stressed, you're distracted by other things. And now you have, to sit down with this family and tell them something really important. And your head is just not always in the game, if you will. If you're in your office, lots of frequent interruptions, or you're running out of time because the family has a lot of questions. So when you find yourself in a danger zone, these are the kind of things you do. I would say, as you feel yourself revving up, should be your signal to slow down. Like you feel, I'm really tense, or I'm really, whatever, having a lot of feelings because of all those things that have happened. That should be a clue to you, slow down, take a breath, bring a bottle of water and take a sip to gather your thoughts, slow down and check in with the family, which is like I say, can you just help me understand what was that you were trying to ask? Just slow down and know you don't always have to have all the answers on that visit. You just don't. And there's ways to bridge it to the next visit. These are the kind of questions I like to ask when I think we're done. Have I left anything out? Is there anything more you need to tell me or share at this point? Do you think I got a good snapshot of your child? Do you think this was a valid evaluation? Because if they don't, whatever you tell them, they're not going to really believe. Do you feel like you have a good sense of what to do next, and what else do you need today? Just, you don't have to ask all of those, but the idea is that you're opening the door to letting them tell you what's on their mind. These are some references. Okay, so I'm going to stop sharing and then we'll come back to the role plays. Okay, any comments, thoughts from anyone here? Or if Jason and Julie want to chime in, please do, and then we'll dive into our role plays.
Yeah, I will say, and good evening, everybody. Hello to the folks who've met me before. Hello to new people. A little while back, Carol showed a slide of the sort of thought bubbles of what families might be thinking. And sometimes I'm fond of using those. So families will ask, if I do this treatment in this intensity, what's the chance of success? And I might say, sometimes when families ask me that, they're wondering, will my child go to college? What kind of a life is my child going to have? And that's a way to sort of open things up to allow families to voice their fears. Because often the question, yes, they may want to know, but there's always something behind it. And if you're able to give voice to those feelings, I think you get yourself out of the trap of it's 20 questions, but it doesn't feel like it's going anywhere.
That's great. A lot of people will also ask you questions like this. What level of severity does my child have? And I think I don't know how you guys handle that. So I don't want to go down a rabbit hole on this, but I don't tend to use the levels. And every single parent is hoping you're going to tell them it's mild. Or they'll say to you, this is mild, right? This is mild autism. And it's a really tricky question when people ask that. And that happens a lot. The other thing that I get more and more these days is, so do you think there's a really good chance that my kid's going to outgrow this? I just think those are hard questions. How do you guys handle those? I'll ask Julie and Jason. You must get those questions as well. So how do you handle those?
Well, maybe I can go. Yes, you absolutely are going to get the severity one without a doubt. I think I do what you do, Carol. I don't answer it, especially in these younger kids, right? Because it is these younger ones where I think we aren't as clear as what they're going to look at like. And I'll say that to a parent. I'm not sure I can answer this question with a lot of certainty for you now, but over time, I probably can do a better job. So that's how I dodge that. I say I'll answer it later with more certainty.
Yeah, I also will say this story is going to get clearer over time. And I do tell people, though, I do tell people, I don't like to talk about mild, severe necessarily, because I don't, but I do talk about where I see vulnerabilities. So I will say, here's what I think you really need to be working on. It was really difficult to get your child's attention during this evaluation. And that's what I think we need to be working on, in early intervention and in ABA is really, using treatment to consistently get your child to respond. And parents, that will resonate, if you will, because they know how hard it's been to get their child's attention as well. Any other questions or comments about giving feedback? Any thoughts?
There's an opportunity here to talk about severity is relative, and there are ways to, as everyone's been saying so far, this idea of different pockets of ability. And sometimes it's helpful to just go into the how severity is measured without even having to land on any kind of rating, because that is going to fluctuate over time.
I'll make one other comment, by the way, about this. When we talk about strengths, we've sort of conditioned ourselves to say, oh my God, it's so atypical to be so hyper focused on numbers and letters and stuff like that. But I will often say to the parents, wow, your kid is like incredibly good at this stuff. or wow, your kid is, your kid has a real incredible skill. Like you watch these kids who are doing like incredibly complicated puzzles. Yes, they may be very hyper focused on it, but I will say to them, your kid has a skill there. It's not a usual way that you see these things, but I do sort of make a real point of sort of not just acknowledging, appreciating those skills, and not just looking at them through the lens of being atypical. Yeah, have you ever watched kids who like they line these things up in ways that you're just like, they're seeing something differently than the way we're seeing it. They just are. I mean, I've watched kids who put these things together and you're like, holy cow, like, wow. So I do try to appreciate those to families as well. All right, we're doing all, does anyone else have any comments or thoughts, or have had any experiences with giving difficult feedback to families that they want to share? And I can't see everybody, so just jump in if you do want to share something.
I just have had a few friends in my personal life whose children were recently diagnosed with autism, like in New York City and other places. And I've had two different people say that they felt like when they were getting the diagnosis, the provider they felt like the provider thought they were telling them really terrible news, but that they felt that the news was really welcome because they knew this about their child and they really wanted their child to get help and support. And these are high functioning kids, so they knew their child was likely to be very successful in life. They just wanted this diagnosis so they could get the ABA, and they felt like the provider was kind of like thought they were telling them something terrible. So I had just heard that two different times recently.
Well, it goes back to what I was saying is don't pre-guess what you think someone's going to be feeling. And I'll tell you that sometimes with what you're saying, that people feel a sense that we are communicating pity. It is toxic to communicate pity to somebody, in my opinion. It's a strong word, I said, but I really do think nobody wants to be pitied in life. And that is sometimes what people feel like, poor you. And I think we really have to be cautious about that. Any other thoughts?
Well, I had sort of a question and I guess a comment, because even if I haven't necessarily given an autism diagnosis, I've certainly communicated that I had significant concerns, and that was maybe a step in that. But I think I do wonder if all of us actually have experience giving, or most of us have experience giving bad news or suspecting something really serious. A kid who you send to the emergency room because you expect that they have really severe congenital heart disease or something like that. So it makes me wonder if, we maybe don't have the autism diagnosis experience, but it feels like a lot of the concepts you're introducing about having these discussions are like what we might say with a severe medical diagnosis that might have long-ranging implications to say, look, I'm concerned about this thing. I'm not sure what it is. Might they need surgery? Yes. Do I know how this is going to work out? I don't. We're going to connect you with the right people and we're going to try to figure this out, but it's important that you go there now, et cetera, and so on. I guess I'm bringing it up because I think this is a special case scenario, but I also think that it feels like, maybe I'm wrong, but it feels like we have relevant experience talking to people about really difficult things. And that should be at least somewhat empowering, and we shouldn't be cavalier about it, but it feels like there should be some
that's right.
empowerment
But
from that.
I have a question for you. So, I thought about this. And so does it feel the same? This is a question. When you say to someone, I'm concerned and you need to go to the emergency room, whoever it is they're seeing in the emergency room is making the diagnosis. They're the ones telling them. Is it the same? I don't know. Maybe it feels the same. Maybe you'll say, oh, it feels the same. But I wondered if, like, saying, I'm really concerned about this, you need to go to the emergency room, is you're not yet making that diagnosis. Somebody else is going to.
Carol, I think the difference is if you're having to do that, you're having to convince the parent who maybe didn't want to go, didn't realize it. If they knew, they'd go. If they knew how serious it was. So I think the difference that the situations I think Brian's referring to is when we're having to tell somebody about something that we know that they don't know yet. something on the labs, something
Yeah,
about the
yeah.
exam that they haven't figured out. And so I think that's where you have to do the convincing that it is new news that you still have to give just to get
Do
to
you
it.
feel like it's it's fairly similar to then giving the diagnosis, John? I don't know.
I
Anyway,
think
what we,
well, I think in some ways, just because I think sometime preparing people for
yeah,
something that is
yeah,
life changing, it has that feels very parallel. Again, I don't know that it's exactly the same, but it feels
yeah,
like it's in the neighborhood and has to be sensitively handled. You can't really beat around the bush necessarily. You can't say, "Hey, you should go to the emergency room. I'm really concerned. See you later." To say, "Look, there's a chance this is really serious. There's a chance you actually
yeah,
might need,
yeah,
heart
yeah.
surgery or something like that." And so again, I was just wondering if this is
No,
just
no, I think
experience
it's,
that we
I
could draw
thought
on.
about that and I'm glad you brought that up because I really wasn't sure if they're the same. I do agree, they're in the neighborhood. You'll find out. And when you do this, if it feels, I'd be curious when you make a first time you really diagnose and you're the guy who is saying it, if you say, yeah, that felt kind of same. I think it's a good point. Let's go on to doing the role plays. And here's what I would love to do, but it's up to you guys. And it's a little different when we're on screens versus in person. Maybe I'm gonna have, I'll pick on Julie and Jason to maybe do the first one. But then if anyone else wants to give it a shot, we can. And we don't have to do them all, but we can have fun with these, honestly. Okay, so let's see what the first, let's take a look. Why is my, there we go. Okay, let's see. So let's do the first one. Two parents present who disagree with the diagnosis. One accepts and agrees, and the other doesn't, and they challenge each other and you, the clinician. Okay. So all right, so we have one parent who said is agreeable, one isn't, and the one who isn't is going to be challenging to the parent and to the clinician. Okay. So I nominate Julie and I to be the couple, and Jason, you could be the clinician. How's about that? Julie, who do you want to be? The person who is agreeable or the one who is the more challenging?
I would prefer to be agreeable.
I knew you were going to pick that one. Okay.
You gave me the
Okay.
choice, Carol.
So let's do it. We'll just do this for a few minutes to see how Jason finesses his way around something like this. All right. Go ahead, Jason. Get us started.
Sure. Julie, Carol, good to see you again. Thanks for taking time with all of those questionnaires, all of the evaluations. It was so helpful to be able to observe you both on Zoom and for you to come in and to see Debbie in the clinic and to see her play. And it was really delightful. I'm wondering, do you have any top of mind thoughts before I share my findings with you today?
Why don't you go first, Julie?
I think the evaluation went really well, and I'm really curious to hear what you have to say, Dr. Fogler.
Okay.
Yeah, I'm kind of curious too, Dr. Fogler.
Okay. So, as you recall, you came in, there were some concerns that Debbie wasn't making friends as well as you'd hope she would in school. She's so bright. We saw that in the clinic. Really loves her numbers, really loves her colors. And, what I remember is you had a bit of a difference of opinion about, was she too involved with the academic stuff at the expense of playing with other kids? Am I tracking with our conversation?
Yes, I've had that concern for a long time.
I'm not that worried about it. She's like, she's social enough.
Yeah. And we talked about, I want to make sure I get this right. There was a birthday party where, Julie, it struck you that all the kids were playing and were really kind of, gathering around the person playing the games. And Debbie was just kind of off in the corner popping bubbles.
That's right. I knew at that point that something was not right and that we needed to get to the bottom of it to help her.
Okay. And you remember we did that series of games, and one of them was I pulled out the bubble gun. Do you remember that?
Mhm.
Mhm.
And what did you make of, I was wondering if you had a similar experience, right? I was spraying those bubbles, and Debbie was popping away and certainly was happy with the popping. But when I tried to offer her the wand, she didn't take it. When I tried to kind of exchange a smile, hey, I get that this is fun, she didn't really look at me. Didn't really look at either of you either. I don't know if you remembered that during our time together.
I remember it. It made me think back to the birthday party in the first place where she was enjoying the party, but it's as if the other kids weren't there. She enjoyed those bubbles, but I don't know that she cared that you were there.
I think she did look at me actually. I mean, she doesn't even know you, Dr. Fogler. Like, I just don't think she was that interested in you. I think you're making a kind of a big deal about that.
No, that's true, right? Kids certainly a new person. There might be some shyness. There might be some reluctance. For what it's worth, we've seen a lot of kids here, and we are accustomed to. There's one type of kid we see who, yeah, they're not so interested in me as a person, but they're connecting with someone in the room, right? They're connecting with one of their parents, or they're really kind of vocalizing, hey, I don't like this guy. um I don't know about you. I kind of had the sense that she was kind of indifferent to my being there. I might as well have been a chair in the room. And
I
I
just don't
wonder
think
if
she
you've
knows
ever
you.
had that. Sorry, go ahead, Carol.
I just don't think she knows you so much. And I just have to say, her mom totally babies her all the time, and like is always like so just worries about everything.
Mm,
I mean,
everything.
really, like she's like a really smart little kid, and she's a pretty happy kid, and mom just like worries about everything she does.
I really want to hear what Dr. Fogler has to say because I'm really worried about her.
Okay, I'm gonna pause this
Okay.
for a minute. You can sort of see how this can kind of degenerate. So if it starts to degenerate where, because
Oh,
an
I don't know if it was
aggressive
going to
parent might
degenerate,
be
but
like,
yes, it was.
well, blah, 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 blah. What would you do, Jason, at that moment?
Well, so there's an opportunity there, right? That there's different levels of worry. And if we went far enough, I might have asked you, Carol, Carol, something in you came along here. And I'm wondering what that's about. And maybe that's a chance for Carol to say, I'm devoted to my family. I'm devoted to Julie, that there's some common ground here.
Yeah. Yeah.
And my sense is, as long as we can keep this conversation going, I don't need them to get to yes today.
That's right.
It's more about them coming back and seeing me and sharing this story of their daughter. The bubbles happen to be a salient thing, but my guess is there would be other opportunities and other stories where you gradually kind of build up the narrative together.
I
I'm
mean,
curious what other folks noticed as we were going through this.
I'm sure you guys in primary care see parents who are disagreeing about stuff all the time. I mean, that's got to be bread and butter to you guys, seeing that stuff, right? Yeah, but I thought Jason sort of checking in like that along the way, and I do think sometimes you end up saying to families, "Wow, you guys, you have very different perspectives about your child." And so how should we, I don't know, sort of at least acknowledging that. Just in the interest of time, that let's do one more. And then what we'll do is decide, does anyone want to volunteer or not? Or we'll just see what everybody wants to do. Hang on. And then we'll call it quits for the night. Okay, which one do you guys think is a good one to do? We have time for one more. I sort of like scenario 2 because it hasn't really happened, but it could happen, I suppose. With the first cohort, it doesn't seem like it hasn't happened. But Which one would you guys like to do? Just call out. I can't see everybody, but call out a number.
Scenario 2.
2 looks good.
2?
2.
All right. Oh yeah, I'm like, shoot, I can't. I'm having internet connections. I see here, so I'm having trouble stopping sharing because I'm getting like the wheel turning, and you can see my screen is frozen. You know what? I'm going to disconnect because I'm like losing. I'm going to try to disconnect because I'm losing Zoom, and you guys can try to start that, okay?
You want Jason and I to start?
Yeah, or if anyone wants to volunteer, please do that, okay?
And I want to nod to Victoria's really astute question. What do you do if there's not enough time? I honor that, right? I say, gosh, this conversation, it's really important. I don't know if we're going to be able to get through everything in, 10, 15 minutes. And so, I might just, set the stage to, hey, we should really follow up on this again. Parents will pull really, really hard for you to, just call it and get out of there. And it rarely goes well when it's rushed and it feels like it was sort of yanked out of you. I really do try to slow things down if I can. But the request was for scenario 2. So, oh, you're welcome, Victoria. Is there anyone who would like to be the clinician? And give these skills a whirl? Or do they want to do more of the
I think it's me.
Okay, all right.
I don't see any hands. All right,
Okay.
you want to be the patient and I'll be the clinician?
Sure.
Okay. All right. All right, welcome, Jason. Thank you for coming today. We're gonna talk about the results of Bobby's evaluation. First, I normally, I'm gonna go really fast here. So these are the symptoms I saw, and I'm really concerned about what I saw. I think that he is meeting criteria for autism. Is that what you were expecting me to say today?
So, Dr. Bickle, let me just stop you there. Did you get the 10 articles I emailed you before I came?
I did, thank you. Yes.
And did you have a chance to read them?
No, but thank you for sending them, and I can certainly look into them later.
Okay. I think it's going to be hard to have this conversation. I sent you 10 articles about pathological demand avoidance. And, I'm wondering, why we're jumping to autism when there's all this literature out there.
So as we talked about earlier, this evaluation was for autism, and I do feel like he is meeting criteria for autism. Were you expecting me to tell you that today?
This clinic has a reputation for, you're going to go and get an autism diagnosis. And I was kind of hoping for more here. I was hoping for some more thoughtfulness here. And, I did send you some articles. You all have a really, good reputation. You're all teachers. I was hoping you might do a bit of reading rather than just go, here you go, autism. I could go through a drive-through and get that.
It sounds like this is not what you were expecting to hear today, and I am sorry about that. We can schedule more time to talk about this, but I also think, I think you're right to question my level of expertise. This is a difficult diagnosis to make, right? And as we've talked about, there isn't necessarily blood work or a brain scan I can do to tell you definitively that this is a diagnosis. And so I'm glad you're asking about my expertise. I have taken special training to be able to give this diagnosis, but there are certainly other avenues that we can explore if this isn't sitting right for you right now. And we can certainly talk about those things. We can talk about referral to another specialist. We can talk about talking about this in another follow-up appointment.
And seen.
And seen. And I just want to say, I'm getting texts from Carol saying she's having internet difficulties, so she's probably out. So we're gonna finish up.
And so just quick, so show of hands who has encountered that sort of, grilling and, random articles and, okay. So thank you for the validation. And, one thing I'll note, I really appreciated how Julie just kind of like stepped back, opened the space. Yeah, when in doubt, sidestep. I think it's too easy to get into the whole back and forth of, pathological demand avoidance isn't a thing. And, that would have been a tug of war that, probably would not have kept me engaged in the clinical relationship.
Carol, did you get to hear that? No. Oh, you're on mute. All right, she's out.
She's out.
Okay.
Bad internet. Oh my God, what did I miss?
You're back. You're back.
What did I miss? You got onto great. I'm on like twice, I think. Okay, what did I miss? You were talking about pathological demand avoidance. I leave for 5 minutes, and that's what you got into?
Yes, Jason gave me a hard one.
And Julie settled the waters.
It's 8:30. I'm calling all done.
I think we do.
I don't recall seeing that as a case, but oh my goodness. All right, guys, excellent. Keep up the good work. We are actually working on making these little video clips for you to watch and to code. So I don't know if you want to say
We'll circulate a follow-up email later in the week, so people can look out for that. But thank you guys for your participation, and yeah, definitely keep up the sort of practice work however you can with whoever you can. I think it's gonna be really valuable. Take care, everyone.
Good night, everybody.
Thank you.